So, psychedelic medicine and education, preparing for a splash or the coming storm. So today we're going to be talking about the current regulatory landscape of psychedelic medicine and why this talk may be timely. We're going to talk about the need for educational opportunities for trainees in this particular discipline. We are also going to talk about current opportunities here at Johns Hopkins and other places, as well as educational scholarship. And so again, I am a medical educator. I came here to do education and am really passionate about educational scholarship being a pathway forward in academic medicine. And so I want to really pay attention there and highlight opportunities for trainees who are thinking about this path, because it's a viable one and it's a joyful one. So stay tuned. I'll start out by acknowledging my extraordinary colleagues at the Psychedelic Center. The fact that I get to play with these guys and help them out on their clinical trials is an absolute privilege and a joy. They are doing extraordinary research and incredibly thoughtful, and so many of the studies and opportunities I am talking about today are really a reflection of their hard work, and so I want to be sure to acknowledge them. It's a really extraordinary and kind team. So what is the current landscape of psychedelic medicine? I think this is the first place to start just as an educator. There's a lot of misconceptions actually about what is currently available. So I want to be clear. Psychedelic medicines, in particular, psilocybin and MDMA, are not currently approved for clinical treatment. So there are some exceptions to this. I could have an entire lecture just talking about the specifics of those exceptions. In particular, there's a program called Supervised Adult Use, where in states like Colorado or Oregon, there are pathways for individuals to have psychedelic experiences. This is in contrast to the biomedical model. So again, I won't be going in depth there today, but if you hear about Colorado and Oregon, that's why. Ketamine and S-ketamine is kind of an interesting exception in that ketamine is not a classic psychedelic, it's a dissociative anesthetic, but has been occasionally used in a psychedelic treatment model. If you took our didactic course, you understand the distinction between the biomedical model, the psycholytic model, the psychedelic model. But for our purposes, we're really going to be talking more about psilocybin and MDMA, because again, there are other kind of more biomedical opportunities to experience ketamine. And then psilocybin may be on the horizon for clinical approval in the next year, potentially even early 2027. So I hope that all internally makes you gasp, because I gasp. I can't believe that. Is this true that psilocybin is really going to be an FDA-approved medication next year? And it's very, very possible. And that a pharmaceutical company completed their phase 3 trial and is now on a rolling admission with the FDA. And so based on that data, many have the strong suspicion that it will be approved early next year. And with that, clinical launch could take place about, and again, this is based on my most recent information, probably this time next year, which is pretty extraordinary. So, given that this is on the horizon potentially, I'm curious about how do we learn about psychedelic medicine now? And the reality is we learn mostly from popular media. I am not trying to be critical at all of How to Change Your Mind, which is a delightful documentary on Netflix that Michael Pollan produced, a follow-up from his best-selling book, How to Change Your Mind. But this is a medical educator. I don't want this to be true, that the number one source of our education on these medications is coming from the media, from sources that are not psychiatrists or clinical researchers. And so I think we're at a moment in time where better educational offerings are warranted, not just for the public, but also for our medical trainees. So how do we prepare for this? How do we prepare for something that could be on the horizon? And I think that's really an important and sobering question. There are a lot of limitations and real-world risks to psychedelic medicines. I'm going to talk a lot about that and how we emphasize that within our course in particular. But also our patients have questions. I think the most common thing I hear is, gosh, my patients ask me about microdosing all the time. Like, what do I tell them? I always, just to be clear, as, again, an educational moment, I don't recommend microdosing or any recreational use of these medicines. I want to be clear that when I am educating about psychedelic medicines, I am doing so within the psychiatric context and the biomedical one. And so I really think that making that distinction for our patients is very important, but also for all of us today. So when I'm talking broadly about psychedelic medicine, I am really confining it to the clinical space. But anyways, just an aside about microdosing, there are actually really profound risks to it. There's something that I think many people have the misconception that micro means better, that somehow a smaller dose is safer, when in fact repeated activation of the 5-HT2B receptor at the heart can lead to structural heart disease. So the model that we're talking about today, the psychedelic treatment model, does not require that kind of repeated dosing. So it's actually much safer, even though we use much higher doses. So a little clinical pearl for you, but that's a good example of a question that you will be asked as a clinician all the time. And being able to say, gosh, let me tell you about the clinical context and why there's some safety parameters there versus recreational use is incredibly important. So again, we really want to equip our trainees to counsel our patients, and we all want to be better prepared for this if it's coming so soon. So actually a lot of different disciplines are grappling with this. It's not just psychiatrists, but also nursing and other health professionals. There's been a number of survey studies where one of the biggest concerns is just the lack of educational opportunities to get good, grounded, balanced, evidence-based information about psychedelic medicine. And so a project was born here at Hopkins and Yale and NYU. So this was when I started here. I actually began work on this project when I was finishing up my chief year at Penn, and then came to Hopkins to do a clinician educator fellowship with a focus on psychedelic medicine. I joined Natalie Gukassian, who tragically left us to go to Columbia. And so, but this is a really cool project. And so we received a grant to develop curricula specifically for psychiatric trainees, really wanting to equip them with foundational knowledge about psychedelic medicine as we prepared for a potential landscape where more psychedelic medicines had been approved. So this project started in 2022. There was 11 of us actually as part of the team, which was very, very fun and very interesting to get 11 academics from 3 different institutions to agree on the single most important learning points for resident physicians. So we had some great conversations, but actually we're very aligned on some of these foundational competencies. The intention was that this course would be taught live at each institution, and that it could be expanded in the future for fellows. So I have to shout out Johns Hopkins here in that there is an extraordinary legacy of medical education scholarship, specifically David Kern, who was a professor in the Department of Medicine, established the standard for medical curriculum development. And so there are courses on this, and if you go to any academic conference talking about medical education, they will mention Kern's model of course development. I'm going to go through this step by step to talk about how we developed our curriculum, but it's important to know this is a good Hopkins shout out. And so it starts with a general needs assessment. What's our healthcare problem? Why are we doing this? And for us, that was that there was a real lack of balanced evidence-based educational materials for trainees. We conducted a general needs assessment, which in this case was a survey study that we did for residency training directors across the country. So we emailed couple hundred training directors to try and understand what they thought. We thought, you know, you guys are defining resident education. What to you is important? And we learned a lot of really interesting things. First, we learned that typical programs only offered 1 to 2 hours of didactics total across the 4 years in psychedelic medicines, or none at all. And so we were like, okay, it does seem like there could be a bit more here. We asked them how much more they wanted. They said not too much, just maybe 3 to 5 hours. We made a course that was 6 hours. We just kind of pushed it a little bit. And we also asked them, what do you feel like is most important? What do you really want them to know about this new field that maybe you're anxious about, or maybe they're asking you about? And number 1 was safety, efficacy, ethics, psychopharmacology, harm reduction. And so we use this not to just say, hey, this is what we think is important in a curriculum, but this is what you think is important. And we really want to make sure we honor that collective wisdom. Some other things we learned from this study was that the barriers to providing more education were really around lack of materials and lack of faculty willing to teach it. And so we recognized that we were truly meeting a very specific need, and many institutions were interested in a standardized curriculum. And so after going global, we went very local, and then I got to speak to Jimmy at one point, and Anne and others here about the viability of a course on psychedelic medicine. I was met with a lot of institutional support, which was really extraordinary, and I, credit this community for being so opening and welcome. We kind of envisioned where it might be best to implement this particular curriculum. And we got clear on our goals and objectives. This is a key educator's note that learning objectives, you see them at the beginning of every lecture, but they matter. And what I remember learning as a fellow was that objectives are not just cognitive. It's not just about what you learn, but it's about how you feel, how you go away from something, what your behaviors are. And so we had predominantly cognitive objectives, but also affective ones. We wanted to instill a sense of confidence in residents that they could speak to their patients and really understand the risks and benefits of these treatments. We piloted and we developed, and it took us a while to get this thing off the ground, but we maintained our track. We had both didactic components as well as a practicum experience. And then, of course, we went into implementation in this last year and taught it across 4 institutions. So Natalie Gukassian is in this picture also, but there's a number of other researchers and members of our team from Yale, Hopkins, and NYU here. And of course, this year we managed to successfully pilot the course. So a word about evaluation. I love surveys. This is helpful as a medical educator because it's important to, they say that if you don't measure something, did it actually happen? And so it happened, and I will promise to share our data with you. But it's important to be mindful that there's many things that we can capture with assessment, one being learner assessment. So what did you score on our pre-test versus our post-test versus course assessment? How did the course actually go? What did you think about it? Were there things we could have done better? I'll say that not all assessment is made equal. This was another really important learning point for me, is that a lot of assessment is about, again, did you like the course? Yes, hopefully, God willing. But also we want to know, are you really learning? And how can we tell that you're really learning? Further, how does this impact your behavior? Because ideally, when we teach something, it does something real in the world. And then finally, are we seeing the impacts of this course long term? Does it impact the institution, the system, our patients? And so our goal was at least to get to level 3 with this particular course. And so this is what we made. We had 6 hours of didactic content focusing on an introduction. We covered psilocybin. We covered access to care and inclusion within psychedelic medicine, We talked about MDMA, ketamine, and then finally, psychedelics in the real world, really trying to target some of those specific patient questions that come up all the time. How is this really going to look when our patients are considering going to retreat? How is this really going to look when one of these medicines is FDA approved? Who is not a good candidate for psychedelic treatment? Very important considerations. Things, again, that we were very thoughtful to include: safety, clinical evidence, pharmacology, mechanisms of action, phenomenology, and of course, ethics. And then we launched it. I know we have to acknowledge any AI thing. This is totally an AI Hopkins colored rocket launch, so I just want to shout that out. So again, we taught this course. I actually taught it here and at Penn, where I had previously trained. We had about 41 enrolled, and this was mostly PGY4s. Occasionally we had other folks present. We convinced 34 of them to do our pre-survey, and we had 22 to complete our post. And this was done both as an elective and embedded within the curriculum. So here at Hopkins and Yale, it was an elective. At NYU and Penn, it was embedded within their course. And so this was not just psychedelic enthusiasts who signed up, but rather it was mandatory for 2/3 of the folks who participated. So curriculum outcomes. I have to acknowledge Prachi, who's here, who did our wonderful data analysis. I am an educator, not a primary researcher. Stats have never been my strength, and so I want to give credit where it's due and just express my heartfelt gratitude. And so what we learned is that this was a well-received course. People thought that it was excellent, which was great mostly, or at least good. Knowledge increased. 100% felt like they learned something. Thrilled for that. And we asked about behaviors, and what we found is that over half were discussing or counseling their patients about psychedelic medicine following the course, which is, again, helpful. That was our goal, and we're glad we met it. So a few other things, and again, I don't want to spend too much time on data-heavy slides, but what we found is that the self-assessed knowledge we saw significant improvements pre and post, as well as actual knowledge quiz scores. We created a test and asked them basic questions about the mechanism of action and certain kind of more granular details about psychedelic medicines, and we saw folks actually did better on our post tests, so weren't just saying they learned, but demonstrated it. We asked them just about their general beliefs and understandings, kind of, do you think psychedelics are viable for the future? Do you kind of understand why we're looking into it? And what we found that most people kind of already had some interest or knowledge of psychedelic medicine from the start. The one where we saw the greatest increase, and this was not our most significant finding, but one of the most, is at the pre-test saying, I understand the specific limitations of current clinical research in psychedelic medicine. We saw that very significantly increase to post-test, and that folks were not as clear on those limitations, and then we made them increasingly so over time. And again, how confident do you feel counseling patients about these topics? The pros and cons of psychedelic medicine, again, seeing that statistically significant increase. Counseling patients about harm reduction. And then our single most significant finding, I believe, was around counseling about the limitations of research and the specific risks of clinical psychedelic medicine. So again, I point that out to say that our goal was not to create enthusiasm or folks who were ready to go out and prescribe psychedelic medicines, but really felt confident in their clarity around who would be appropriate for this care. What are the risks? What are we still learning in a research context? But also, hey, there might be some folks where this could be clinically meaningful or useful. So again, takeaways from our outcomes, confidence counseling, risks and limitations, really increased pre-post. We started with some significant interest, even though this was mandatory for 2/3 of them, and that was unchanged. We didn't make them less interested, which is great. And that their knowledge increased, both subjectively and objectively measured. So what does this So what does this mean? It means that you can create a standardized curriculum on this. You can teach it at 4 very different institutions in the Northeast and find that it's well received. And there's opportunities to do more with this later, whether it be sharing with other academic institutions or offering kind of online delivery of the same content. So practicum considerations, I have the beautiful Anne Rubel here, who was such a wonderful support and a true champion of psychotherapy education here at Hopkins. And so I think one of the coolest things about the practicum is that we are essentially practicing psychotherapy in dyads, which is really unique. You're sitting with another therapist and you're watching them and participating in a shared process of discovery with the patients, and which is a really, again, it's enriching for everyone involved. And so, of course, when these 3 joined us, we each were assigned a participant together. We spent about 3 months with them, 2 to 3 months, engaging in either psychological support or supportive psychotherapy. Again, there's a whole other lecture that I'm actually giving at APA tomorrow about the distinction for those, and so I won't go into that, but essentially for our purposes, we'll just say co-facilitating psychotherapy, and it was really a very meaningful experience. So I have to shout out Karen in that initially in this slide, she gave me some feedback on my presentation. I had a picture of Freud in the Hopkins colors, and she said, "Bit, you're at Hopkins, this is Jerome Frank." And so unfortunately AI couldn't make a good enough rendering of Jerome Frank, so I've just put in persuasion and healing here. So thank you, Karen. Yes. So this is not all we're doing. Again, I think curriculums are awesome and working directly with residents is incredibly meaningful. And yet there are other opportunities for sharing knowledge about psychedelic medicine and other areas of psychiatry. This year, the Pocket Guide launched or relaunched their update. There was a number of new sections added, including one on psychedelic medicine. So I again congratulate my colleagues on that achievement. Myself and Jada Sayali, who's a wonderful researcher at the center, helped edit the particular section, and so this actually many of our residents contributed to, which was really lovely to have, as well as center faculty. So this is now kind of a clinical companion for providers to offer some basic context for psychedelic medicine. And then we tried out CME. This was a real learning edge, as you know, again, to use an educational term for me, which was, what does it mean to share didactic content, not just with those at your institution, but elsewhere? And so we developed and had our first day-long CME course on psychedelic medicine about 2 weeks ago. Meg Chisholm, who was my mentor and coming to Hopkins in the fellowship program, was like, you know you can do a CME. And I was like, Meg, I can't possibly do a CME. And she, of course, had done her own and really encouraged us at the center to give this a shot, and it was a wonderful success. Thanks in part, of course, again, to all of the CPCR who participated. But just to give you a sense kind of how it went and who came. So we had about 49 registrants with very little time to promote it, actually. We had mostly physicians, over 55%, but also PhDs, LCSWs. We had a lawyer, which is interesting, just that this has reached beyond medicine. And we had a number of specialties represented. So psychiatry, psychology, but also internal medicine, emergency medicine, neurology, anesthesia. So in kind of a cross-disciplinary interest in this particular area. We have future dates planned as well as subsequent courses on the horizon, we hope, in the future. And so again, I want to acknowledge some of the work of my colleagues, just to say that again, medical education in psychedelics is expansive, and there are many different ways to make an impact. Al Garcia Romeo is publishing an APA textbook on psychedelic medicine and psychiatry. He very kindly shared an up-and-coming image of the textbook itself. The CPCR faculty participated in a Coursera course, a MOOC, which David Yaden, no relation, was the project lead on. And one of our wonderful psychiatric therapists, Chrissy Arthur, leads a clinical internship program. So along with our residents who are rotating with us, we also have counseling students who learn to facilitate psychedelic medicine. So in summary, just to get us ending on time, educational scholarship, I argue, is a viable path toward career development and hopefully career advancement. Again, I love being an educator. I love working with residents. I think it is a joy and a privilege. And so I am gonna hopefully keep doing it as long as I can. And again, really appreciate the opportunities here to do so. Health education scholarship, again, has a strong tradition here at Hopkins, both in our department as well as others. It's really wonderful to be a part of that. And again, through previous fellowship programs as well as ongoing educational opportunities, you can take a year-long course in curriculum development and teaching skills, which I did when I was a fellow. And that there are opportunities beyond just psychiatry, and that medical health education can be for those of us who are providing care but also receiving care. And I look forward to seeing psychedelic medicine education grow in the future, to again provide this kind of grounded and balanced education in an emerging and hopefully increasingly evidence-based field. So with that, I just want to express my gratitude and say what a pleasure it's been to be with all of you this morning and at Hopkins in general. Again, I can give AI credit for this very sweet-looking mushroom. But I'm so grateful, of course, to the CPCR, to the folks, my colleagues, to develop this curriculum, Jimmy for giving me this wonderful opportunity, Natalie, Ann and Jake, Meg, Durga, Costas, my wonderful residents and students, and of course our research participants. So thank you, everyone. I really appreciate it.
Thank you, Dr. Yaden. What a great educational program. Great array of program activities. I'm curious if you have a sense, based on your experience, I guess, in fellowship curriculum development and in this recent webinar, do you have a sense of what the biggest misconceptions people come into to the educational experience with? What are the biggest things they need to get clarity about?
I think that's a great question. I think actually it's, our goal is to kind of middle folks out. We get misconceptions about psychedelics are gonna destroy psychiatry on the one side, a lot of heavy skepticism that may or may not reflect the evidence. On the other side, we get super enthusiasts. People think that we're gonna stop needing our tried and true tools because psychedelics are going to save us, and that's absolutely not true. And so I think that the role of education is really to kind of get folks a little bit closer together in the middle of seeing promise, but also really wanting to clarify where those risks and limitations are. So that's what I would say.
Makes sense. Great. Thanks. Folks have questions? Dr. Margolis.
Love it, yes. Again, learning objectives are my love language, and so I'll say that there is
want to repeat the question?
Yeah, absolutely. So this is about, like, what do we really want residents to walk away with? What is it that we're most hoping to impart for them? And I think there's an important distinction between education and training. this is an educational course. We want people to have, as you said, increased knowledge overall. The expectation is that we're not giving them enough knowledge that they themselves can then go out and start their own psychedelic clinic. I think that there is a lot of other things that trainees would need to learn to do that. And again, I think that we're learning as an institution and as a country what those kinds of trainings may entail in the future. But for us, it's really about that confidence counseling, which is, I think, whether or not these medicines become mainstream, as you said, or are FDA approved, we are being asked about them. And so I think it's really our job to make sure that we're equipping our residents with the right information, that they feel confident saying, gosh, you know, it sounds like your mom has a history of bipolar disorder. I don't think you would be a good candidate for this kind of clinical trial. Or, you know, it sounds like things are very unstable in your life right now. This may not be the best fit for you right now. Or, you know, sure, let's look at the criteria to get together and see if you're a good candidate. So again, I think that was kind of our greatest hope, and it was a surprise actually that those were the outcomes we saw where the pre-post changes were most pronounced. So thank you for asking.
Great, thanks. Other folks, Dr. Schwartz.
Dr. Yagan, that was terrific. So if we're talking practically about how to move this from elective to part of our curriculum, could you tell us the parts that you think all psychiatric residents should experience and the parts that might be more elective?
I love that question, thank you. I appreciate it, Dr. Schwartz.
What should all residents get?
Yes.
And what should be
what should be opt-in versus opt-out? Or, you know, how... And I think the distinction between the didactics, I think that didactics were very successful when we had them embedded at certain institutions, and so I do think that that is applicable whether or not you're interested in psychedelic medicine or not. This is a new emerging drug class in interventional psychiatry, and it's important that we all understand some of those limitations or risks as well as the potential there. I think the practicum is a very unique experience, and I think it is best suited for residents who are highly motivated to get involved. It actually is very labor intensive. I will say that we were able to get in a few residents this year, but it takes a fair amount of time in terms of coordination and their commitment and reconciling with their schedules. And so this is best for those who are passionate either about learning more about psychedelic medicine or those that are very interested in psychotherapy training. Because again, I think there are some unique opportunities there. But I think that would be the distinction that I would make, is that those more hands-on experience should be for those who really see themselves wanting to learn more as opposed to just foundational knowledge. So thank you.
Great. Other folks? Dr. Morrow.
Thanks very much. After esketamine was approved by the FDA, pretty rapid proliferation, and most are seen of non-FDA approved uses, intravenous, sublingual, with some consequences. I'm wondering from an education standpoint, I don't know that there's been a lot of education about necessarily this for instance, in general prescribing. I'm wondering if you have ideas for how to get back the education out there for psychedelics that are only a year out from an FDA.
It's a great question. Again, I think that, you know, esketamine and ketamine is a really interesting example because a lot of the ways that it is being used clinically is actually not in a psychedelic treatment model. And so it's kind of an interesting bird in that way. But I think your question is well, you know, well taken in that what are we going to do if suddenly there's 1,000 psychedelic psilocybin centers of treatment in the next year? Like, how can we possibly, how can our healthcare system educate the number of providers needed to do this responsibly? And I love that question. Again, I'm sorry that it's unfortunate. I'm 9 months pregnant right now and about to go on my maternity leave. And so I am meeting regularly with different folks who are passionate about this education to think, how do we scale up? How do we begin to provide the the public, but also healthcare providers with the kind of grounded evidence-based direction that they deserve to do this responsibly. So I think there's a number of vehicles for that. It's actually why we started our CME course, really with a mind to saying, okay, we at Hopkins do probably by numbers the most psilocybin facilitation sessions than any other place in the country, to my knowledge, maybe the world, just in terms of volume. We have many, many clinical trials and have a lot of experience. And so with that, we understand acutely what the risks can be in a clinical setting, and we're eager to share that information with the world. And so I think CME is a vehicle for that. I think the kinds of residency-based curriculas are that. I'm working with an organization that is developing curricula for a speakers bureau that's going to kind of disseminate evidence-based information. And so I know a lot of people are very excited to ask this question, and I think it's never been more important. And that, these are, I remember a professor of mine in residency said, powerful medicines have powerful risks. And so I think that in acknowledging the potential of psychedelic medicines, we have to be very clear about how to do this as safely as possible. So hopefully many things.
Thank you. Dr. Sloan.
What do you imagine would be needed on top of what the program already includes to graduate residents or other trainees from Hopkins that go out and be leaders? Should this be FDA?
I love the word leaders.
What would it take to prepare Hopkins to be leaders when they go out from training?
Yeah, I love that. And so I think that there's, again, our center is such a privilege that it's here, and that many of the faculty there are, currently doing kind of leaders more nationally and globally in this area. And so I think it would be a dream if we were graduating residents who then in turn becomes leaders themselves. I think that, you're a perfect example, Allison. And Allison came to us as an intern saying, I really want to learn about this. Had a chance to contribute to our pocket guide. Hopefully will be a part of our elective in the future. But I think, increasing opportunities to integrate our clinical program with our research program is really essential. And so I see a lot of potential for Hopkins graduates to be future leaders. And I think as we increasingly integrate those programs, we'll see more of that. So thank you, Allison.
Other folks, Dr. DePaulo.
Thank you very much for this, and I appreciate your clinical, limiting yourself to the clinical experience, but also you mentioned yourself, microdosing. Sasha mentioned that bad experiences some of her patients have had previously. Is there going to be an experience for a well-educated person in psychedelic medicine to have experience with people that have issues?
Yes, that's a great question. Let me make sure I'm understanding. So you're curious in particular about, gosh, we're talking about clinical implementation, right? But what are we doing for the people that are in the community using these medicines and having bad experiences, which absolutely happens. And so, again, this is an opportunity for me to shout out one of my colleagues, Azine Bakrad, who is at Johns Hopkins Personalized Care, and she recently opened kind of a clinical practice for post-psychedelic difficulties. And so the idea there is that she herself has become an expert in some of the side effects or sequelae that can arise following a negative psychedelic experience. Again, because these are not clinically available in the recreational space. And so I think in addition to our goals around educating our residents about the clinical utilization of these medicines, we also spend a fair amount of time on harm reduction. Like, what do you do when a patient has a bad experience? Who can you send them to? What medications should you consider? How do you counsel them about that? So we both have that clinical opportunity here at Hopkins, as well as have prioritized that within our curriculum itself. So thank you.
Thanks. Time for one last question. Did you want to ask another one, Dr. Swartz?
Quick question. You made the case for why we should follow the protocol that you all are doing. If this gets FDA approved, will there be any expectation of that?
Ooh. That's a good question.
Will FDA approval
Yes, and so
require that we use the rigorous and comprehensive kind of protocol that we do here?
yeah, and so again, I think that this is, as a primary educator, I do not have the answer, and I can say that as someone who is very thoughtful about the upcoming clinical launch and really wants to consider how to do that well, I know that some of the folks we've spoken to in industry are trying to navigate that question themselves. And so I think that there are a lot of intentions that the treatment model we use here at Hopkins hopefully exists in the clinical space in much the same way. And what actually happens is anyone's guess. And so again, I'm very hopeful of that and remain optimistic, but again, I think we'll learn a lot in the coming year and hopefully be a part of shaping that and really kind of giving our most evidence-based and safe directions around how to do this kind of care.
Thank you, Dr. Yaden. Thanks for great grand rounds, and thanks
Thank
for
you.
fantastic work in this area.
Appreciate it.